All right, so we're going to talk about how to assess the atrium and the chest tube, but first I want to start off showing you where it normally lies. So if you imagine a patient's laying on their side like this, and then here's the arm. So normally you'll see a chest tube kind of coming out of here, and then we like to put it usually apical and posterior so it can catch any of the air that's coming out. And then, like in last time we talked about taping it more anteriorly, there's normally a radio-opaque line on the chest tube, and then we normally have drainage holes that are added on. So, you know, they're kind of like this. So one important thing to note that we'll come back to later is that whenever we cut extra drainage holes, the last one is always on a radio-opaque line. And that's going to be important later for figuring out where an air leak might be coming from. And I apologize, let me just silence these. Okay, so let's say you've walked into a room and you're looking at your setup and everything like that. So this was the portable suction device we mentioned in the last video, and we're going to turn that on. Our orange bellows out. We have a really crazy air leak. So if you ever see an air leak like this, which hopefully you won't, if it was less prolific than this, we'd say this is a continuous air leak. You don't see it happening just with expiration, and that is important because usually if you see a continuous air leak, that means that there's more of a system issue. So if we're assessing the atrium and what's coming out of it, so first you can look at the amount of liquid you have coming out by looking at this chamber. You're going to want to look at the quality of it. So is it serous? Is it serosanguinous? Is it purely sanguinous? Is it purulent? And then we're going to look at how much is coming out. And oftentimes people ask, you know, when should I call? And I'd say it's more about the trend. If someone has had, you know, let's say 400 cc's of serous fluid out overnight, but they had a pleurodesis for chronic pleural effusions, that's someone we expect to have a very large output. So I'd say that's within the realm of normal. If, say, somebody had a lobectomy and they were draining, say, 50 cc's of serosanguinous stuff overnight, and then overnight they put out 200 cc's of sanguinous fluid, then that's something where you'd want to call a physician. So again, it's kind of about the context and the trends. Now, if we were then trying to assess in this chamber for if they have an air leak or not. So a lot of times we'll see what we refer to as titling. So when the chest tube is here, you normally have the lung and the chest wall, and there's a space in there that's been created because we've disrupted that apposition when we enter the chest. So either fluid or air is in there. So now we have a space, and as the lung kind of moves and expands, it changes the pressure, and then that's when you get the titling. So we'll see that swing back and forth. You also see this little ball move up and down that's in the fluid chamber. And titling is something normal, but if it goes away, that is also something that can be normal, meaning just now that your lung is touching up against your chest wall and you no longer have that space. So what's the difference between titling and an air leak? If you have titling, you may see the fluid kind of undulate and move, but an air leak is when you actually see a bubble come up and break the surface. So that's what you're looking for when you describe an actual air leak. Now, if you have an air leak, like we mentioned, if it's something that's just expiratory, we could expect that after a lung resection because the lung can take time to heal even though we use staples. So once that heals, the air leak will stop. If you have something that's continuous, then we worry more about a system issue. So there are different areas that you can assess. So you can start off looking at your patient and the chest tube site. So if we imagine that this is the incision coming around the tube, if that incision is larger than the tube, it's easy to entrain air and release air from around that site. So you can look for, say, increasing subcutaneous emphysema, look for a continuous air leak. And if this ends up being the problem, then you would let us know and we would do a stitch to kind of close that down. Now, let's say that we don't see anything there. You're definitely gonna want to take this back and also look a little bit further up and see, do you notice a drainage hole? You can also look at your chest x-ray where we talked about that radio-opaque line and see where the last hole is and if it's still inside the chest. If neither of those things are the issue, then you start to see, do we have an air leak along the tubing? And the way you can kind of isolate where that air leak may be is if you pinch off the tube and the air leak goes away, that means that the leak is somewhere above the point that you've pinched it. If the air leak is continuing, that means that you have some sort of issue below where you've pinched it. and you just kind of work your way down and figure out where to like isolate that too. So that would be kind of where we're looking for air leaks. Of note, sometimes if people have had a decortication where they've had empyema or a lot of blood that ends up coming out because we've been working on the lung, people are more likely to form clots and things in the chest tube. So sometimes you may see that they had an air leak and it goes away, or that the titling is decreased. So you also always want to assess your tube for any sort of blockage. It can sometimes be a little deceptive because you can still have draining even though you had a blockage, because fluid can wick along a clot. If we do have someone who's had a decort and they have a clot, what you can do is you can always kind of twist the tube and break up the clot. And then I believe we've shown some of you how to milk the tube before. I would put on gloves, put a couple pumps of the hand sanitizer just to give you some like lubrication. And you basically pull this tube and let go. And that creates a momentary increase in suction that'll kind of help break up that clot and drag it down. We don't like to usually do that on patients where they're freshly post-op after a lobe, or worried about increasing the pressure inside if there's a more delicate stapling. If we ever had those patients, we would let you guys know. But for the most part, we're worried about that after things like decortications. So I think those would be the main things that you would kind of look for with the tube. And again, it's about the trends in terms of the fluid output, and the same thing with the air leak. So just to mention that, if someone had an air leak and it goes away after something like the lobe, we expect that because things have probably healed. If they didn't have an air leak and a new one starts up, that could potentially be an issue, but again, it's about the context, because sometimes people have very small air leaks. And if you have to have all the air come out of this tube in order to see bubbles, if the air leak is very small, when they cough, they may not generate enough air for it to leak. But then over time, over the course of a few hours, they build up some air inside the chest, and then when they cough, it comes out. So if you have an air leak that kind of comes and goes, it could be because that it's really small. So I think that's about it.